Thank you all for coming. I'm Dr. Gittleman, Mark Gittleman, and I'm going to speak about risk. What is risk? What do we mean by that? And then Dr. Guilfoyle is going to talk to you about, once you identify what your risk is, if it is elevated risk, what to do about it. So there's lots of things we talk about risk. There's risk of getting breast cancer. There's risk of having a breast cancer recur once you've had breast cancer. So there's different definitions or different things we use when we use the word risk, and we have to define what we're talking about. One thing that always interested me when we talk about risk, and I'll talk about the program we started here in the imaging center and also in our office, but I always had the patient look at me when I'd say, well, you know, we identified you because of family history that you're 2 times average risk or 3 times average risk. And the patient would look at me and she'd go, okay, and she walked out of not knowing what that meant. And I didn't really know what that meant either. We just say that it's 2 times or 3 times, but 2 times, 3 times what? I mean, it doesn't really mean anything, does it? You have to know 2 times what to make it meaningful. If it's 2 times a very small number, it's still a small number. If it's 2 times a relatively big number, then it becomes significant. So you really want to know what the number is you're 2 timing or 3 timing or whatever. And that brings up the concept of this a thing we call relative risk and absolute risk. So the first thing that I would tell patients years ago would be their relative risk. I said you have a 3-fold increase of getting breast cancer over your lifetime. That's relative risk, relative to the normal population, right? But you have to know what the risk is in the normal population to make that meaningful to you, right? So then I started telling my patients, well, let's figure out not just your relative risk, but what you want to know, what my patients want to know, is the absolute risk. Do you want to know over your lifetime, do you have a 10% risk of getting breast cancer, or 50%, or 80%? That has meaning to you. You know, I can relate to that. You know, my risk is 10% or less, I'm not too concerned. If it's 30%, I'm somewhat concerned. If it's 80%, I'm really concerned. So we like to use the term relative risk rather than, I mean absolute risk rather than the term relative risk. So I just wanted to go over that. So when someone says to you, you have a 3-fold increase, what does that mean? You know, like a 50% off sale. What does that mean? Well, if something costs $1, you have 50% off sale is 50 cents. You're not going to drive, you know, from here to Easton to go ahead and get a 50% off sale if it's 50 cents difference. But if it's a 50% off sale and it's $100 now down to $50, that's 50% off. But the absolute difference is $50, not 50 cents. You see, so it's that whole thing of relative and absolute. Now, we have ways of figuring out what your absolute risk is. What I'm talking about people now who don't have breast cancer and want to know, do I have an increased risk of getting breast cancer, and how can we measure that? How can we assign a number to it? Because once you've assigned a number to it, then Dr. Guilfoyle can talk to you about what you can do now, knowing what that number is. So there's various models out there that are used to calculate your risk, and actually your absolute risk, not just your relative risk. And one of the models that's been used for a long, long time, many of you probably heard of it, it's called the Gale Model. The Gale Model was developed many, many years ago by Professor Gale. It's a statistical model where a series of questions you're asked to put down, you know, how old are you? How old were you when you first started having children? How old were you when you first started menstruating? Do you have any previous biopsies? Do you have a family history of breast cancer, and so on? And it takes into account all those different answers, about 7 different questions that are asked, and puts it into a little calculator or a software program, and you can determine a person's absolute risk of getting breast cancer over the next 5 years or over their lifetime. It gives you 2 answers, the 5-year risk and the lifetime risk. So that's one model we use. It's a statistical model that's used. But there are other models that have come out since then that are much better and more refined. And we use the more refined one called the Tyra Cusick model. You don't have to worry about the name. It's just that it's a more refined model, the Tyra Cusick model. Because that takes into account many, many more things than the Gale model did. For instance, the Gale model would say, history of breast cancer in a first-degree relative. And if your mother had breast cancer, you check off yes. But it didn't ask what age was your mother when she had breast cancer. It's a big difference in your risk if your mother had breast cancer at 35 versus she had breast cancer at 85. You see, so the Gale model didn't take in that into account. The Tyra Cusick takes that into account, which makes it much more meaningful to give you a true risk assessment. So we've been using for quite a while now this thing called the Tyra Cusick risk assessment. Many of our patients we find in the practice think they have a much a risk that's much greater than it really is because of a certain family history. And so patients are often relieved to find out that when we do this Tyra Cusick risk assessment, that the risk is not as high as they perceived it had been. On the other hand, we have lots of women in our practice who think their risk is relatively low, and we run the computer model and whoa, it's higher than they thought it was. So it can work both ways. So it's really good to know what your actual risk is, and we can determine that with these models. What we set up in the imaging center downstairs is exactly this program to identify women at increased risk who come in not knowing what their risk is at all. So what we're doing, we're trying to capture the women that are coming in for their routine imaging, for their mammograms and so on, their screening studies. And Lori has set this up very nicely with the help of a number of her people down there and some of the industry folks to set up a questionnaire. So we're asking women when they come into the imaging center now to fill out this questionnaire. And right then and there, the mammotechnologists who are doing the mammogram can go ahead and put that data into the computer and tell that woman what her risk is using that Tyra Cusick model right away. So it's very nice. The woman leaves not only with her mammogram report, but she also has a risk assessment performed. And it's not only for breast cancer, but actually we can determine also, is that woman at risk for ovarian cancer too? So it's something very helpful that we've instituted here. And I don't know any of the other facilities around the area that are doing that type of thing. So this is a way of capturing people to give them their risk and then go ahead and doing something about it that Dr. Guilfoyle is going to talk to you about. There's other so some of the tools we use once we identify a person who may be at increased risk is using the certain genetic testing. And you've all heard about the BRCA gene mutation testing, the Angelina Jolie testing, okay? So if there's certain things you fill out on that form, we look at that and say, oh, this person should have the BRCA, the breast cancer gene test performed to find out if they are at very elevated risk of getting breast cancer or not. And that's something we can determine when you fill out that form. There's also, well, let me just go back a second and tell you about the BRCA gene risk mutation. Very few people have the BRCA gene mutation. It's something inherited. You get it from either your mother or your father. And if you happen to have that gene mutation that you're born with, there's a very high risk of getting breast cancer over your lifetime, and also ovarian cancer. It's up to 70–80% of breast cancer and 50 to 60% chance you're going to get ovarian cancer. So you want to be identified so something can be done about that. In this country, it's estimated that only about 300,000 affected people in this country that have that BRCA gene mutation, it's estimated, only 5 to 8% of them have been identified. That's a huge number that haven't been identified. Now, we're not going to identify all of them down in the imaging center, but we'll certainly make an attempt to go ahead and identify the people locally that have the mutation. They're walking around completely unaware of it. And if we can identify those people and prevent breast and ovarian cancer, we'll make a huge contribution to their overall health just by running that test, or at least identifying the patients that should have the test run. Mm-hmm. So that's a huge public health issue that we want to help in this community to identify those patients. But as I said, there's not a whole lot. I mean, 300,000 is not a lot of people. It's a big country that have that mutation. But if you have that mutation, it's a very high risk. There are other mutations that exist in our genes, in a part of the DNA structure, which are more common than that BRCA mutation. They're much more common. But the risk, if you have those gene mutations, the risk of getting breast cancer is not as high. In other words, the incidence or the frequency of those other gene mutations is higher than the BRCA gene mutation, but the penetrance isn't as high. In other words, the expression of it, of having a cancer, is not, it's somewhat elevated, but not as elevated as the BRCA. So if you have the BRCA gene mutation, very few people have it. If you have it, you have a high risk. If you have these other mutations, which many more people have, the risk is slightly increased. So we want to identify both ends of that spectrum. And we can do that with certain tests. And the one is, as I said, the BRCA gene mutation test that we run on patients if they meet the criteria. But this other test, for these other mutations, we run with another type of test. That's called the Brevigen test. And that's something we're offering our patients or patients coming to the imaging center to have that test done in addition to the BRCA gene mutation. Because if people have those other mutations there, they're at elevated risk, but not to the same degree as I said. And depending upon how elevated that risk is, remember going back to see if they're, what their absolute risk is, if it's greater than 20% over the lifetime, there's certain things that need to be done that Dr. Guilfoyle is going to tell you about. So we're excited about this program. We kicked it off about 2 weeks ago, 3 weeks ago. And I'll tell you, before we started the program, in our office we'd be doing the test and offering the test to appropriate individuals. And I must admit, probably a lot of people slipped through the cracks because maybe the questionnaire wasn't asked appropriately, or we didn't give the questionnaire. I mean, I'm talking about over the years. You know, we did it, but not. It's kind of on a when I think about doing it, or maybe this person should be tested and so on. But now we have this structured program. We can ask everyone to fill out this questionnaire, capture the ones that we were even unaware that they were at risk. And so we're doing that. We've amplified that much in the imaging center to do that now in the imaging center. So. And so this is huge. We should in our community, I mean, all physicians should be offering to their patients in the community. But let's face it, your doctors are taking care of your diabetes and your high blood pressure and things like that. And they don't say, well, let me fill out this questionnaire to see what risk you are for breast and ovarian cancer. That's not on the front burner. And maybe it should be, but they have other things to deal with too. So this is a way we have of promoting this program here in the imaging center to have women tested or otherwise wouldn't know they should be tested. So. My office manager years ago said to me, Dr. Gittleman, never answer a question about insurance with a patient because you don't know what you're talking about. Refer them to us. And we promised, the staff said, we promised not to do the surgery. So it's worked out well over these many years. So addressing those insurance questions, it's important. But I'm not trying to, foof it a little bit. I'm not trying to do it at all. I'm saying, but it's best to answer by the administrators. Okay.